going.
Chapter 13?
No, I think did we finish 12? Or were we still on? I forget this one or the insurance one.
All right, let's see.
I do have a mark on page 207.
Yep, actually you are right. So we'll pick
Okay.
up there and then go into pharmacology.
Yeah.
You got it. Yep, I had a little sticky note there too. We left off on nonverbal communication.
Yeah.
All right. So down at the bottom of 207, some patients are covered under a type of insurance that requires them to choose a primary care physician and have to be referred to a specialist. So patients, they don't like change, so they don't want to have to change. So we have to set a good impression. We want to be personable. If the patients get a bad impression when they first walk in the door, then they're more apt to want to change providers, and whether that be a specialist that they were referred to, or it can be a primary care office as well as staff changes and everything like that. When using the electronic health record, we need to make sure nonverbal communication send the right message to the patient. So eye contact with the patient when we're asking questions, even if we're filling out a form, making sure that we're looking up and watching or talking to the patient with our eyes as well. Modify the stance. If you end up standing while you're talking to the patient, or even if you're sitting in a chair, they say it's better to sit even sideways to be able to look at the patient than having your back to them and having them answer questions behind you. And I know most of the offices that I've been in, when the MAs are taking the information, they're more or less on the side, so I can see them and they can turn and see what I'm saying or listen to what I'm saying. On 208, patients have the right to make decisions in most aspects of their health care plan, so therefore choices need to be offered to the patients. The medical assistant needs to promote time to think unless the patient is faced with a critical, time-sensitive decision. So most of the time, patients, if you're giving them an options of medications, for example, they're not going to pop right then and give you an answer. They're going to need some time, whether or not that's time that the patient needs to leave and call, or whether it's time that can be allowed for in the office to make that decision and then have it in place. Make sure timely communication is done with patient, and any additional orders that need to be put in place are completed. So even if they've left the office and they call back and that order for that medication is going to take place then, make sure that process is complete. There's a way to follow up. So at the end of the day, if you've got 5 of your patients whose charts can't be completed because things are out there lingering, whether or not they need to make a decision and get back to you about where they want to go for a test or something like that, make sure you have a way to follow up on that. Don't leave that up to the patient, because then 2 weeks later, the patient could call and say, I never heard from you on that MRI. And you're like, well, I thought you were going to call me. But there's got to be a process in place to follow up. That seems to be a big one for us that falls through the cracks. Also make sure patients understand all instructions given to them regarding testing procedures or preparation for procedures. So typically a verbal communication with those instructions is great. A handout with what you just told them is a good reinforcement. That way they have something to physically look at home other than try to remember what you told them. Backup systems for your electronic health record. Even the most expensive EHRs can't function without power, so there has to be a backup system. If that electronic health record goes down and there's no backup system, that's why a lot of doctors did not want to switch to electronic health records. because the paper they knew was there and they knew they had access to it. If the electronic record goes down and there's no backup, what happens? They've lost everything. So some of the ways that these can be backed up and saved are external hard drives, which connect to the main computer. They can copy the information in the EHR daily. 7 electronic folders, 1 for each day of the week. Some offices, when these, depending on the times of days that they back up, some offices will close their day, like say at 4 o'clock, and start their backup for the day. When that backup is done, whoever is responsible will take that tape, that backup tape, they take it off the premises and they take it home with them. That way, even if something happens at the facility, that backup disk is somewhere else. It's kind of hard to do if it backs up overnight. If it backs up overnight, the best thing you can do is somebody that next day still takes that tape disk and they take it home that night, because that way if something happened during, let's say today, Wednesday, at least I have Tuesday's backup that will give us everything up till this morning when we started functioning. A full server backup. This can be done on a dedicated server, large capacity computer specifically for the EHR. They do a full server backup typically monthly, and that's the full thing, whereas they do like brief backups daily. Online backup system can be used. That's typically for a fee. Although the cost may be higher, online systems are easy to use because there's no external drive, nothing to carry around, no thumb drives, anything like that. So all of these backups require alternative power sources in case of disaster. So any of those are usually recommended for best protection. Medical assistants should still keep up their paper chart skills. Just in the instance that we are not going to be able to use electronic health records, you can still see patients with regards to their problems, write everything down on paper, and then that paper can get entered into the computer. It's pretty bad when your physicians rely so much on the EHR during the day. If they had to shut, after that last storm, they had to shut down power in our area, in our office area for an hour because they had to reconnect certain streets in. And while that power was out for an hour, our physicians were completely lost. They said, "We can't see anybody." Well, why can't you see people? We're going to do it the paper way, just like you used to. Write everything down. Then once we get the power back on, you can transcribe. It beats, having to send these patients away and reschedule them, especially if they've been waiting for appointments. Right. Transfer, destruction, and retention of electronic health records. So typically you're going to have active files, which are current patients receiving treatment, inactive, which are patients who have not been seen within the last 6 months, and then closed, which are records for patients who are deceased, no longer located in the area, or their relationship with the doctor has termed. So we do want to have a way to purge these files so that we only have the active charts in one location, and then the inactive and the closed. The closed do not need to, especially if you're paper charts, your closed charts do not need to be where you keep all your other charts. They can be kept in a completely separate location, and then depending on the state laws for medical record retention, they can be destroyed after a certain point. So we want to have a way to purge those files from active to inactive, or even from inactive back to active if they come back. Retention and destruction, we have an obligation to keep those patients' charts, whether they're paper or electronic, according to the AMA, and we need to have a retention schedule. So we need to check in our state to see what the law is on how long we maintain those medical records. For example, operative notes, chemotherapy records, they should always be part of the patient's health record. Laws regarding retention of health records can vary state to state, and some of the government programs have their own laws regarding record retention. When there are no rules that specify the retention of health record, rule of thumb is keep them for 10 years. However, for minors, the facility usually keeps the record until the minor reaches the age of majority plus the statute of limitations. So you have to make sure that those minor charts are following under that. They have to be the age of majority plus the statute of limitations. If a patient record no longer needs to be kept for medical reasons, again, check the state law to see what needs to be done. And the time, like if you have to keep them for 10 years, it's 10 years from the last date of contact with that patient. Some may be 3 years or longer. Again, in the case of a minor, the statute of limitations may not apply until the patient reaches the age of majority. So again, keeping that in mind. And what we do on a yearly basis is we will go into the state of Maine and we print off what their retention rule is so that we know how long it is. And we just keep it with our medical records department or whoever takes care of purging our charts. So that way, every year we know whether or not that has changed and what we need to do. Medicare and Medicaid, again, which is federal, must be kept at least 10 years. Some providers refuse to destroy old records. Again, it's fine to destroy them after that time limit if you've had no contact with them. Before they are discarded, you should give your patients the opportunity to claim a copy of them, not the original record, but a copy. You should also keep a master list of all records that have been destroyed. That way, if a patient comes to you and says, I had something done and you can't find anything, you can look back and say, yes, you were a patient here 15 years ago. Those records, we only have to keep them 10 years. They've been destroyed. Because that is true. We don't have to hang on to them. They can resurface, 15 years later. But we need to also give the patients the opportunity to claim those records. So a lot of times that can be done by sending out a mass mailing, going into your practice management system. It will print labels of patients. The problem with that is if you haven't seen them in 10 years, how do we even know their address is current? So you can make a good faith effort and you can put an ad in the paper, which a lot of offices will do. And they just put an ad in the paper and they will say medical records prior to whatever will be destroyed. If you have records and wish to obtain them, contact. And that will happen too for practices that are closing. But that's an easy way to do it. Releasing health information. We have to be careful when we release information. We obviously have to have a patient signed release saying it's okay for us to give them that information. It does need to be in writing, including specifically who the information is being released to, what information is being released, and they need to say how long that's good for. So typically it should have an expiration date on it. Most offices will have the expiration date be a year for patients, and then after that point they would need to sign a new release. If a provider is involved in a liability suit, there will be an exchange of information. But again, on each occasion that information is needed from the provider, a separate request must be sent. We have attorneys that they're sneaky sometimes, and they'll send us a request stating we need billing information and medical records from September 2nd, 17th to present on so-and-so, but they don't attach an authorization. You can't send them that information just because their attorney's office asking for it. Patient signed a release, so they need to send it to us. Most offices charge a fee to print copies of health records, whether it's per page or per record fee. Typically, if it's electronically, that's not going to happen. There is each state has I don't know if you want to call it a law or a proposal of what can be charged for medical records. And typically, there are two for the state of Maine. If it's like attorney's offices, I was trying to think what else, but typically attorney's offices, you can charge $10 for the first page and 35 cents for each page thereafter. If it's actually the state requesting those records, so let's say the state of Maine disability or the state of Maine workers' comp fund, that is $5 for the first page and 45 cents for each page thereafter. If you can charge for medical records, it will be on the request that is sent to you. Have whoever is copying medical records let you know how many pages it is, and then bill for that, because they're offering to pay. You're using paper, it should be submitted to them. But again, make sure you know what your state's recommendations are for that. Pay particular attention to records released involving a minor. Most cases, a parent or legal guardian is entitled to read through the patient's health record. However, according to HHS, there are situations where the parent may not be legally entitled to view those minor's records. When the minor is one who consents to care and the parent is not required to consent to their care under state law, when the minor obtains medical care at the direction of a court or a person authorized by the court, or when the minor, parent, provider all agree that the doctor and minor patient can have private, confidential relationship. So we have to be careful with what we are releasing. The only difference is in the case of a minor with possible abuse. That needs to be reported. Some patients want to look at their own records, and they do have a right to that information. Remember, you always keep your original health record. They should only receive a copy. When the release is presented to the office, copy only the records requested in the release. So if they send you a release and say they want records from January 2017 to present, only give them that. Even if the patient's been a patient there for the last 5 years, don't give them anything they are not asking for. That opens you up to a whole can of worms. With regards to mental status, substance abuse, and HIV, that needs to be a separate release completely. That information cannot be released as part of the medical record. If you look on 210, there's an example of a medical authorization. So who the information is going to, patient name, date of birth, social, what information they want released, and why do they want it released. Personal use, continued medical care, whatever it happens to be. Signature, date, complete only if information is to be released directly to a patient. And this one has the doctor signing off saying that it's okay to be released. In the case of a legal issue, I would have the provider do something like that. If it's just a regular medical request going to an attorney or another provider, then I think whoever handles your medical records, as long as they have it documented that they are taking care of it, that is fine. Health information exchanges, so this is sending health information from one healthcare facility to another. There are currently 3 forms of health information exchange. Directed exchange, so this is sending and receiving secure information between care providers to support coordinated care. query-based exchange, ability for providers to find and or request information on a patient from other providers, and consumer-mediated exchange, ability for patient to aggregate and control the use of their health information among providers. And this also can vary state to state. Creating an efficient paper health record management system. Again, information needs to be documented accurately. Corrections if need to be made, also need to be documented properly. How should the health record be organized? The traditional patient record is source-oriented, so that means observations and data are written down according to their source. So we have progress notes from the provider, labs, x-rays, op notes, referral notes. Forms and progress notes are filed in reverse chronological order, which means the most recent is always on top. You can have a problem-oriented medical record. This kind of goes a little astray from the regular, but you can have a 4 categories: a database, including the chief complaint, present illness, review of systems, physical exam, problem list. So every time they come in, there's a date and what the patient is being seen for. The treatment plan, management, additional workups, therapy, anything like that. And each plan would be titled and numbered to the pertinent problem. And then progress notes, which also are numbered to correspond to the appropriate problem. If a doctor does it this way, you will typically see that their progress notes are documented in what we call the SOAP fashion, or SOAP, subjective impressions or patient reports, objective clinical evidence or observation, assessment or diagnosis, and plans for future treatment. Some medical records also offer an E in the record to represent evaluation. So again, a couple of different ways that you can set up paper medical records. Documenting in the electronic health record, a lot of it is drop-down boxes or little clicks here and there. You bring up your patient, it will have a history, and it will give you little boxes that you click, click, click. The health history forms that the patients fill out, you type in, but a lot of the boxes are meant to be checked off, or they're dropped down. So if they're dropped down, you have to make sure when you're scrolling that you are selecting the right one. It's very easy to scroll by it. When you document in the paper record, you always want to start with a date, and that's month, day, year format, followed by the time. And that can be standard or military time. If you look on page 212, this is an example of a problem list. So you can see it's got 12, and then after those 12, you would put a new sheet on top and start all over again. If you are using the paper chart, all entries must be written in black or blue ink. Documentation needs to be in order in which the steps were completed. And how do we make corrections to a electronic health record, or not electronic, excuse me, paper? Make sure that truly we have a correction to make, and we do not erase, we do not use correction fluid or other type of obliteration. How we correct it is draw a single line through the error, insert the correction above or immediately after, where it can be read clearly. If indicated by your policy and procedure manual, you could write error in the margin. And then the person making the correction needs to write his or her initials below or above the correction, depending on space, and date it. Errors made while using computer are corrected in the usual way, electronically, and there's always a date stamp that goes along with that electronic, so we always have a way to go back. If something needs to be changed at a later date for a handwritten record, typically it goes in as an addendum. So this might happen in the case of a patient reviewing a chart. Let's say they asked for their note from the last visit, and they take it home and they read it, and they're like, I never said my father had this cancer. So when they bring that up at their next visit, rather than go back and cross it out, what the doctor does is he does an addendum that just states, upon patient review of records, father did not have whatever, this type of cancer was documented improperly. So it's added as an addendum instead of going back. The only time we cross out and use our initials is when we notice it right away. Dictation and transcription. There's voice activated software. This decreases the need for transcription, but there is still a lot of offices out there that do dictation, which means that they are talking into a recorder and somebody is typing their notes. And that can be done in electronic health record. There's that way it can be done, and then there's the electronic voice activated. The problem with the electronic voice activated is that they have to get used to the doctor's voice. If the doctor is dictating in a noisy place, it may be less apt to be more accurate. So dictation can be done using machine transcription or portable transcription machine. Also a telephone machine. They can call into the system, use passwords, document the information while they're on the telephone, and then it's transcribed into the health record. The provider does need to acknowledge and initial all transcription before it goes in the record. It's not just typed and put there. They need to review that to make sure that what is being typed was actually what the provider said. Again, there's the voice recognition software. They learn to recognize the user's voice. Transfer, destruction, and retention of paper health records. As with the electronic health record, paper health records are also classified as active, inactive, and closed. So again, we can have another means to destroy paper records as we do electronic. You will see, if you look on 215 up in the right corner, if offices have paper charts, you will see a lot of them use a year sticker on the folder. And that indicates the last year the patient visited the office. That way, it's pretty easy when you are merging charts that to keep if you're keeping 2 years worth of charts in your front office and the rest of them are going in the back, as long as the stickers are on accurately, you will be able to merge your charts pretty quickly and easily. Retention and destruction, the same for paper as for electronic health records. Long-term storage for facilities can be done on microfilm. If the facility has not yet begun to scan documents into EHR. Even when those records start to be put into EHR, again, they must be regularly backed up for storage. Another option for transfer paper records onto optical disc. Microfilm and optical disc are both expensive, probably not practical, but another option. And that way these can be kept indefinitely. They do not need to be destroyed. In your office, some of the equipment you might see, especially if you have charts, vertical 4-drawer filing cabinets, manila folders. If you deal with paper charts, they might be color-coded as far as identifying the patient's name by the first 3 letters of the last name and then the label with their actual name and the year. Some factors considered when selecting filing equipment: the office space, structural, cost of space and equipment, the volume of records, confidentiality requirements, how easy it is to get to those records if you need them, fire protection, and cost. So again, just going through quickly the different kinds. You have the regular draw files. They roll easily, close securely, should have a locking device. The drawback on the vertical files is one person at a time. Horizontal shelf files, they should have doors that lock to protect the contents. Open shelf units hold files sideways, so you typically can put them higher on the wall because they don't need to be pulled out. There are rotary circular files. They can hold large volume of records. Several people can work on one rotary at a time. One disadvantage is that they afford less privacy and protection. Compactable files. If you have a small office, great volume of records, you might use this. This is a variation of open shelf files. Automated files, very expensive initially, more maintenance and than other types of filing. So this one, when you press a button indicating what shelf you want, it will bring that shelf out, pull it out for you. But of course with that, you've got all that electrical stuff that can go wrong. So if something does go wrong, you may not be able to get into those charts that are in the middle because the electrical isn't allowing you to pull them all out. We had one of these systems and in the old office I was in, and what they ended up doing is they had so many problems with the electrical part of it and the shelves were so expensive that what they ended up having somebody have to do is somebody actually put in like an old-fashioned crank wheel. So each side of the shelf had literally a crank that you would crank in order to get the shelves to move. And then you had about this much room where you could fit down between the shelves and you could look at the charts that were here, or you could turn around and look at the charts here. But you might have had, L here and M here. So then when you were done and you needed to go to A, you needed to go back out and you needed to crank to get to the A's where they would open up and you could get in them. We had people that, don't ask me how, but people that would not pay attention that there were already people down there looking for records because it was in our basement. And they would come down and they would start cranking and there was somebody in the little space looking for a chart. So that space would start to close and that person was in there. So those you have to be really careful about. Card files, typically this is used for like patient ledgers, patient index. Your library typically has that type of thing. On 216, filing supplies, pretty straightforward. Dividers, out guides. The out guides are usually red, so if you pull a chart, you can put that in so that somebody knows that chart is out. They also have ones where when you pull out a chart, you actually write the chart name and who has it, so that if somebody else is looking for it, especially if it's a larger practice, they know where to go. File folders, these can be tabbed, colored, tri-cut. Some are different weights than others. Hanging or suspension folders, heavy stock, lighter weight, depends on what you are using them for. Labels for filing and finding devices. A label on the drawer or shelf identifies the nature of the contents. If it is on a chart, it will have your patient's last name, first name, and possibly their date of birth. Labels are available any size, shape, or color to meet individual needs of facilities. Narrow label applied to the front of the chart folder is the easiest to use. And again, these labels can be handwritten or they're very easy to go into a printer and print out with a Word document. Indexing rules. These are standardized and based on current business practice. So Association of Record Managers and Administration, they actively update these rules. They do need to be consistent in your practice, so you don't want to use one method for active patients and one for inactive patients. But you can see down at table 12.2, last names are considered first in filing, then the given name, and then the middle name. Compare the names beginning with the first letter of the name. When a letter is different in the two names, that letter determines the order of filing. Initials preceding a name beginning with the same letter. This is the librarian's rule. Nothing comes before something. When hyphenated personal names, hyphenated elements, whether first, middle, or surname, are considered to be one unit. Apostrophe is disregarded in filing. When indexing a foreign name in which you can't distinguish which is the first and which is the last, index each part of the name in order in which it is written. Names with prefixes filed in the usual alphabetic order, with the prefix considered part of the name. On 218, abbreviated parts of the name are indexed as written. MAC and MC are filed in their regular place in the alphabet. The name of a married woman who has taken her husband's last name is indexed by her legal name, and you can have a way to cross-reference that if you want to list the previous name after. When followed by a complete name, titles may be used as the last filing unit if needed to distinguish between another. Terms of seniority or professional or academic degrees only used in the case of identical names. And then articles are disregarded in indexing. So 3 basic filing methods: alphabetic by name, numeric, or subject. So your alphabetic, that's the oldest, simplest, most commonly used. We need to make sure that we have the correct spelling of the name. And as your number of files increase, more space is needed for each section of the alphabet. So we have to allow for that expansion. And as the files expand, more time is required for filing or retrieving each folder. And that time can be reduced if we use a color-coded system as well. The numeric filing, this can be combined with color and shelf filing. Numeric filing is an indirect filing system. It's one that requires use of an alphabetic cross-reference. It allows unlimited expansion without shifting of folders. It provides additional confidentiality to the record, and it saves time in retrieving and filing records quickly. So again, numeric, it depends on the system that you're using if you assign your patients numbers. Middle digit filing begins with the middle digits, followed by the first digit, and then finally by the terminal digits. Again, I don't know that you're going to see a lot of numeric filing. You probably are going to see more of alphabetic. And then you have subject filing, and this can be either alphabetic or alphanumeric. Color coding, both filing and finding files is easier, and misfiling of folders is kept to a minimum, because you will be able to see that color does not belong in there if, for example, BA for, let's say, Bartlett, B is blue and A is yellow, and you have, within the BAs, you have a chart that is purple and green. You're going to know that that chart does not belong there. It is not filed correctly. Alphabetic coloring, again, these are self-adhesive color-coded letter blocks with either 2 or 3 letters. They come in rolls. They come in sheets too. And depending on the cost is going to be dependent upon what you chose. because as long as you stick with the same company, the colors would remain the same except for the years. The years will change colors. The letters are in pairs, so they can be seen from either side of the record. So it kind of creased in the middle and then it comes up over the chart like that. Numeric color coding, numbers 0 through 9, so you could do it that way. Other color coding applications, small tabs in a variety of colors can be used to identify certain types of insured patient. So, for example, if you wanted to be able to tell your Medicare patients, you might put a blue tab on their charts. If it's a workers' comp case, you could put a black sticker, whatever it happens to be. Every person in the facility who uses the files needs to know the key to the color coding, and the key needs to be written down in the policy and procedure manual as well. Organization of files. It should be emphasized when a patient record is not in actual use. It should be where it belongs, in the filing cabinet, on the shelf. It should not be left on somebody's desk. Patient's full name in indexing order should be typed on a label attached to the file folder. And then a lot of offices will put either a strip of transparent tape over that so that you can't, make changes to the patient name, or they have special adhesive that you can put over labels. Health-related correspondence needs to be filed in the patient's health record. General correspondence, if it pertains to the operation of the practice, then possibly you have a special drawer or file cabinet for that, or maybe in with a practice manager. If it's pertaining to payroll, maybe it belongs with human resources in their file cabinet. Only things that are pertinent to the patient's health record should be in the health record. Explanation of benefits that you receive for payments, those do not go in the patient chart. Those are filed completely separate. Miscellaneous files, papers that do not warrant individual folder, place in a miscellaneous file. Related materials can be stapled together. Never use paper clips. When as many as 5 papers accumulate with one correspondent or subject, then you should create a folder for it. Tickler or follow-up files. So a tickler file is in chronological order, and the tickler file can be part of a computerized health record or just one that you set up yourself. And what this tickler file is, you can set it up however you like, but what I find is I have an accordion that goes by month, so it goes January, February, March, April, May, so forth. And if I speak to a patient this month and they tell me to follow up with them in January with regards to their disability or something like that, I'll take that correspondence in which I'm speaking to the patient and I file it in behind January. And then every month I go through and I will follow up. Oh, you're back. Can you hear me?
Yeah, I can hear you. We lost
All right.
connection. We lost our internet for a few minutes.
Oh, did you? Okay.
Yeah.
Well, that's all right. I kept rolling anyways, so.
That's fine. That's fine.
Yep. I'm on 221. I was just talking about the tickler files. So I was saying with the tickler files, it's a good way for you to follow up on anything that you may need to. So if you have patients that you told them that you were going to follow up in a month to see how they were doing on a medication, you could have a folder or some way to follow up on that. They do have alphabetical, like accordions, and they also have the month ones. So depending on, and number ones, depending on how frequently you have to follow up, you told a patient you'd call them in 4 weeks, you could use the number one, and you could put that, whatever date fell in 4 weeks, so that you would be able to follow up with them on that. Transitory or temporary file. Many papers are kept longer than necessary because there is no provision for that. So you can put a copy of something in this type of folder until it needs to be destroyed, or until it's asked for, or until you no longer need it anymore. Some things you need to keep indefinitely, and then there are going to be other papers that are only pertinent for a little while, and then they're going to be able to be destroyed. So in closing, again, just as in every aspect of the medical profession, the medical records are changing rapidly, allowing providers to manage their duties more efficiently and accurately. So we have to adapt to the changes, especially with the EHR and technology. We want to, again, provide high-quality patient care, in which the EHR is helping the providers do that. And EHR will be constantly changing and growing, so there's always going to be a learning curve. Some of the EHRs are geared towards the specialty, and others are geared just towards every practice in general. Patients worry about security of their patient information. So let's make sure we educate the patient. And that's done also with our Privacy and Policy Acts. We're not going to give out that information unless we have a signed release from them. We had a lady call the other day, and she has moved. She's now down in Florida, and she wants a copy of her record. Well, she thought by calling us on the phone and saying it's okay to send, we would go ahead and send it. And we explained that with HIPAA, we actually have to have a signed authorization saying it's okay for us to send them even to you as the patient. So educating the patients, making sure they're aware of that control that we have on that. Again, authority to release information solely with the patient unless a release is required by law through a subpoena, for example. And remember that the record belongs to the provider. The information belongs to the patient. And the patient does need to authorize what they want released, who they want it released to, and how long that release is for. Any questions on the health record?
No?
Nope, pretty straightforward.
It is.
All right. We will start with pharmacology. So with pharmacology, again, you can see that you've got your vocabulary in the front, but we're going to talk about the medical assistant's role in preventing drug abuse, differentiating a drug's chemical, generic, and trade name, looking for drugs in reference material, safety measures for over-the-counter drugs, relating pharmacokinetics to drug use, and factors that affect the action of a drug. So again, pharmacology is the origin, nature, chemistry, effects, and use of drugs. And clinical pharmacology is the study of the biological effects on a drug used as a medical treatment. So as medical assistants, we should have a general understanding of the types of drugs available and their uses. We should also know maybe some typical side effects that may be a result of not just that medication, but any medication such as rashes or fevers or anything like that. Different routes of medication, the administration, and some recommended dosaging. Now, we're not going to be the ones prescribing, your physician is, so they obviously are the ones that are going to know the medications much more completely than us. But it's nice for us to be able to have access to go look something up if a patient's calling us and telling us that they are having this reaction, where you may not know right off the top of our head if that's a common side effect, but we know where we need to go look it up and get that information and then pass it on. Several federal agencies regulate, safeguard, and manage medications in the United States. The FDA, Food and Drug Administration, which is a department of the Health and Human Services, they regulate the development and sale of all prescription and OTC or over-the-counter drugs. FDA approval needs to be obtained before the drugs can be sold to consumers. And when there are new drugs being tested, typically only 1 out of those 10 drugs actually make it to the clinical testing phase. So a lot of the drugs, it could take several years or revamping in order for it to actually make that stage. Once the manufacturer of the drug is awarded copyright protection from that chemical, they are awarded a patent, and that patent expires 20 years from the date of filing. So during that 20-year time period, that means that no other pharmaceutical company can produce a generic form of that medication. They have to wait until it is near expiration, and then they can apply. Controlled substances, the DEA, Drug Enforcement Administration, developed in 1973. They're part of the Department of Justice, and they regulate the use of illegal drugs. According to controlled substance, a drug or other substance that has the potential for illegal use and abuse needs to be placed on this controlled substance list. Most controlled drugs to patients are given for pain relief, anesthesia for surgery, for example. But there are guidelines for complying with storage of controlled substance, record keeping, and the security requirements. Federal law mandates all medical personnel, including medical assistants, share responsibility for managing those controlled substances. So the guidelines that are set forth for the controlled substances are divided into 5 sections or scheduled, depending on the addictive ability or the degree of abuse of that drug. So Schedule 1 drugs are illegal, cannot be prescribed, to Schedule 5 drugs, so 1 through 5. Schedule 4, limited number of states have that. That's for the marijuana and synthetic cannabis products, so not everybody would have a Schedule 4. But every medical practice that stores and administers medications following under any of those schedules or categories have to keep a copy of the controlled substance regulation and follow those guidelines. So the regulation, again, record keeping, the physicians need to be registered, and inventory of those controlled substances need to be kept. Complete, accurate records on purchase, management of the scheduled drugs need to be maintained. They must be kept separate from the patient's medical record for 2 years, and you have to be able to supply them to the DEA if they ask for them. Each time a controlled substance is dispensed and administered, it needs to be documented, number of dosages, drug site, everything like that. Any discrepancy in the count of medication needs to be documented and co-signed by 2 individual people. Every physician who prescribes controlled substances needs to register with the DEA for a controlled substance certificate. They have to renew it every 3 years, so not all physicians may be able to prescribe controlled drugs. Some of the family practitioners may not opt to do this. They may leave that up to pain specialists in order to get that medication. But that DEA registration needs to be obtained for each site. So if the provider has an office in Brunswick and another one up in Augusta, each individual office needs a separate certificate, not just one for the provider. All controlled substances stored in safe double lock cabinet, keys kept in a separate place so that nobody has access to them. If drugs are lost or stolen, it needs to be reported directly, immediately to the regional DEA. There are authorized collection sites that may allow you to dispose of some of these controlled substances. Demerol, Dilaudid, OxyContin, those are just a few that may be disposable among one of those sites. If you look on 228, here's an example of the schedules 1 through 5. So, for example, Schedule 1, never prescribed for use, no accepted medical use, high potential for abuse, and then it gives you some drug examples. Schedule 5, accepted for medical care, low potential for abuse, indicates drug mixtures, so like your cough syrup with codeine, that's a good example of a Schedule 5. But just to give you an idea of the different schedules and how they rank, I would have taken it to Schedule 1 be the worst, but they go the other way. Individual states can regulate controlled substance. So again, we need to know our own state's legal requirements. Specific federal guidelines apply to both written and e-prescriptions. So a written, oral, faxed, or DEA electronic prescription has to have the date the drug is prescribed, name and address of the patient, name, address, and DEA of the physician. The amount prescribed needs to be written out. It's not just the number 10. It would be 10, T-E-N. Provider must manually sign all paper prescriptions for controlled substances. Other specific rules can apply depending on the schedule of the drug. So you can see for a Schedule 2 drug, it can be either written or e-prescribed. Fax orders not permitted, cannot be refilled. Schedule 3, orally, writing, or electronic, may be refilled up to 5 times. And then your Schedule 5. So again, certain ones are going to follow certain guidelines. Drug abuse. So drug abuse, the use of illegal and legal drugs has increased. So we have the possibility of patients having drug abuse. So we need to be alert of the symptoms of drug dependence in order to be able to notify our providers. They're probably going to pick up on it too. But drug misuse is improper use of common drugs that can lead to dependence or toxicity. Examples of people with chronic dependencies, those who cannot have a bowel movement unless they take an enema, or somebody having nasal congestion that they can't breathe without a nasal spray. That is somebody who is dependent upon a drug, for example, not in a bad way, but they're dependent. Drug abuse is continuous or periodic self-administration of a drug that could result in addiction. Drug dependency, inability to function unless under the influence of a substance, and it can be psychological or physical. So your psychological would be compulsive craving for the effects of a substance, habituation, form of psychological dependence without physiologic dependence, so the need for tobacco. Physical dependency or addiction, person's need for a substance continually so that your body can function. This occurs when abused substances produce biochemical changes in the cells. So they rely on it, and if it's discontinued, that's when somebody has withdrawal. Regularities of the type of drug abused, it will have 2 effects on the person, acute and chronic. Acute is what the person feels when intoxicated or directly under the influence of that subject, and your chronic effects would be temporary or permanent physical and mental changes. So you can see that blue box is the medical assistant role in preventing drug abuse. So pretty straightforward, making sure you monitor your patients that call for refills, request health records from other physicians if patients are taking scheduled drugs, so you make sure that you're not over-prescribing. The prescription pads kept securely, secure computers, limited supply of controlled substances on hand, and make sure we're keeping accurate records. A single drug can have up to 3 names: a chemical name, generic name, and a trade name. So, for example, the chemical name of the analgesic acetaminophen is N4. Acetaminophen is the generic name, and the trade name is Tylenol. So the trade name is assigned by the manufacturer, and that is the one protected by copyright. Drugs can be classified by their use. You look on 220, approaches to studying pharmacology. Many terms are combination of the condition to be treated plus the prefix anti. So antifungal, anti-anxiety, antibiotic, for example. And again, just having a little understanding of what the medications are used for will help you. By all means, we're not supposed to remember what all the drugs are and what they do, but we should have access to drug reference materials, which are reference books updated annually or periodically that should be available for reference. You will see that these books have the action of the medication, so what it does in the body, indication, what the drug is used for, if there's any contraindication, any precautions that need to be aware of, adverse reactions, normal dosages and administration, and then how it is supplied or packaged. All drugs will have a package insert describing the significant aspects of the drug, including information of the chemical components. And when you go to pick up your prescriptions from the pharmacy, typically they will do your printout of that type of information rather than you getting it in your actual pill bottle. One of the big drug references out there is the PDR, or the physician's desk reference. This is, again, published annually. It is supplied free to providers if they subscribe to medical economics. Otherwise, it can be purchased. And they do supply quarterly updates because, as you know, things can change. Meds can be pulled. So they do make those updates. Over 3,000 drugs is in the PDR. So they'll give you all that information, the indications, contraindications, the dosaging, everything. The print version of the PDR has color-coded sections, so it's easy to cross-reference. So, for example, the 6 sections for color-coded, the manufacturer's index is white, so that's alphabetical listing. The brand and generic section is pink, again, alphabetically listed. Product category, blue. This is categorized according to drug category. It also lists drugs with similar actions. Product identification section, gray, so that's the actual pictures, so you can see what the medication looks like. And then general and diagnostic product information are white, and that's alphabetical again. So there is an online version, and then there's the print version. United States Pharmacopoeia, National Formulary, USP/NF. This is the official source of drug standards in the United States. So this is the chemical formula for all accepted drugs. So studying the drugs, how do we do it? We take advantage to observe drugs in patient care. We concentrate on the most important drugs. So if you were working in a cardiology office, you're going to concentrate possibly on those drugs prescribed to heart patients more than you would something like antibiotics. Learn about a drug's primary action and use, and then you can expand that to other actions and use. Dispensing drugs. Drugs are dispensed 2 ways, over-the-counter and prescription. So your over-the-counter is exactly that. They're available to the public for self-medication, no prescription. They have been approved by the FDA for general consumer use. For a patient who also takes prescription drugs, that's why they ask when you go to the doctor if you take anything over the counter, because they want to make sure, even though those over the counter ones are FDA approved, they may want to give you a prescription medication that may not work with what you are taking over the counter, or it may have an interaction. So they need to know that information. Most over-the-counter are safe if used as directed on the package. However, patient education contributes greatly to the safe and correct use of the over-the-counter. So the package label needs to be read, take only the recommended dose, monitor expiration date, discard it when it's past that expiration date. Never combine an over-the-counter with prescription unless your provider knows. Recognize that many over-the-counter drugs are contraindicated in pregnancy, nursing, and young children. And check with your pharmacist if there are questions. So again, over-the-counter drugs, they're constantly increasing. So we need to make sure our patients are educated and let the providers know in case there are contraindications. You can see on page 232 a couple of the over-the-counter drugs and what their indications are for. So ibuprofen is a non-steroidal. Its indication or desired effect is for pain relief. Some of the side effects, and it does not interact well with ACE inhibitors or warfarin, which is a blood thinner. And again, we may not know that information unless we're reading the package insert, but the pharmacist would be able to tell you, or your provider. Then we have prescription drugs. So federal law makes drugs that are dangerous, powerful, or habitual or habit-forming. So we need a prescription written by the provider for dispensing. Electronic prescriptions are widely out there now. So a lot of doctors don't even use paper anymore. What the issue with paper is some patients would see several providers in a week, and they would get written prescriptions from all of those providers for the pain medications. And then they would take them to different pharmacies and have them filled. Well, now with electronic prescribing, that's limited because electronically they can monitor it, and the pharmacies will be able to interact with each other and know if patients are receiving that same med at other pharmacies. There's a way for their system now to track that, which is pretty cool. Again, note made in the patient's chart when a medication is given, phoned, or faxed into the pharmacy with all of that information. Even a refill needs to be documented. Otherwise, we don't have any way of knowing or proving that we did it. There are abbreviations and appropriate medical terminology for prescriptions, and we want to make sure that those abbreviations used for writing prescriptions are in your policy and procedure manual. So like, for example, if I am using the letters PO, I know that is by mouth when it's pertaining to a prescription, or IM, for example. On page 232, that turquoise box, 6 parts of a prescription. So we have the superscription, which is your patient information, name, address, and date. You have the inscription, which is the name of the drug, dosage, how you want it, like liquid, pill, and strength. Then we have a subscription, directions for the pharmacist, size of each dose, amount to be dispensed, and the form of the drug ordered. So again, tablets, capsules. The signature, directions for the patient. So like 1 by mouth every Q6 hours, PRN pain, for example. Refill information. This may be regulated by federal law if it is a controlled substance. So it does need to say how many refills are available. And then the provider's signature. And that can be electronic or manual. and it has to have their DEA number on it. So again, those providers that need that special DEA for the controlled substance prescription, if they're writing a prescription off their regular script pad and they don't have that special DEA number, they're not going to be able to prescribe it. Again, you can do electronic, or you can see on page 233 the old-fashioned written, but it's got your patient information, the date, their address. The prescription is for Lipitor, 40 milligram tablet. They're getting 30, and it's 1 HS, which is at night or bedtime, and it's refillable 3 times. And then it's got the doctor's signature. And you can see in the EHR, it pretty much looks the same, except it's got the name of the practice electronically, then allows them to check off which provider, and then give the rest of the information. If you look on 234 and 235, this is actually quite nice, and this is a good tool to use. These are the abbreviations that you will commonly see with prescriptions. So what I did is I actually photocopied this and let my doctor, I did it as a 2-sided document and then took off the bottom of the second page, but let them use that as our office policy and procedure as far as prescriptions. So when they're writing a prescription, if they're writing it as QOD, then any staff could go to our policy and procedure manual and know that that means every other day, because some people may not know. But this gives them a good idea. So that's a good tool for abbreviations for prescriptions. On page 236, excuse me, drug interactions with the body. So pharmacology is the study of drug, their effects, and what happens to it while it's in your body. Different patients can react different to the same dose and the same medication. Pharmacokinetics is the study of movement of drugs through the body. And we have 4 basic actions taking place when a drug is taken. You have absorption, distribution, metabolism, and excretion. So if we know what happens to the drug in the body, we can know the onset of the drug activity, so when it starts acting, when the effects of the drug are likely to peak, the minimum amount of the drug needed for the therapeutic effect, and the duration of the drug's activities. So that all helps the provider know how long that patient should be kept on that medication. So the drug absorption is the rate at which it is absorbed at the site of administration into the bloodstream. The ability to dissolve if it's in pill format. And it all depends on the route of administration. So liquid oral medications dissolve more rapidly than solid because they don't have to be dissolved by the GI fluids. They're going right into the bloodstream. Acidic drugs are absorbed well in the stomach, whereas others cannot be absorbed until they actually reach the small intestine. So they take that into consideration. If it's an acidic drug and it can't be dissolved until it gets to the stomach, how long is it going to take to get to the stomach before you actually start noticing that medication working? Some people can take an antibiotic and they take it and 6 hours later they're like, nothing's happening. Well, it may have not gotten to where the effects can be noticed yet. Oral medication, oral route, convenient, safe, relatively inexpensive. Injection of medication leads to rapid absorption into the bloodstream, but this increases the danger of overdose or infection. Oral medications, most of them are absorbed in your small intestines and then carried on to the liver from there. Food slows the absorption of drugs, therefore many medications are absorbed best when they are taken either 1 hour before or 2 hours after eating. Sometimes your food will bind with a medication, so it kind of deactivates it. Tetracycline, for example, is destroyed by milk products or antacids. So if somebody's taking tetracycline and they drink lots of milk, they're completely defeating the purpose of the medication. Because some drugs are destroyed by the components of your digestive tract or irritate the empty lining of the stomach, oral drugs may be enteric coated to keep them intact until they get to your small intestine. So it is important to remember the absorption factors when administering medication orally. Parental route refers to administration by injection. This is the fastest action because, again, it goes directly into the bloodstream or tissues with a rich blood supply. A drug in an aqueous or water solution is absorbed more quickly in an area with more blood vessels. Therefore, drugs put into your muscles are absorbed faster than drugs given under your skin. IM route is chosen in emergency for fast action when a medication needs to be absorbed. The IM route is also used for oil-based medications, also because that's much quicker. The subcutaneous or under the skin route is chosen when you need a slower, more prolonged effect. Drug absorption can also be controlled physically. It can be quickened by hand massage after injection, but this should only be done upon recommendation. Drugs suspended in substances such as oil or insolubles slowly dissolve in your tissues over a long time. The patient can be spared costly, frequent, painful injections. Local anesthetics can be mixed with epinephrine to keep your medication and it affects in the area longer because your epinephrine constricts your blood vessels, so it reduces the circulation. Another parental route is intravenous or IV, where it is injected directly into a vein. Because of the dangers of IV, only medical team members can do an IV. There's also some intrathecal, intraspinal injections, intra-articular for corticosteroids, intralesional medications which go directly into a lesion or a tumor, for example. Another form of parental route is intradermal, which is injection of a drug within the dermal layer of the skin. That one's typically done for allergy testing. Mucous membrane absorption. So drugs that can be absorbed by the membranes in your mouth, your nose, your throat, eyes, rectum, vagina, and respiratory tracts. Your nasal sprays, your eye drops, rectal suppositories. So sometimes, because of the systemic effect that they have, a rectal suppository would be given to control vomiting. Because if you're vomiting, if they give it to you orally, it's probably not going to stay in your system. You're probably going to throw it up. So they give it rectally, and it absorbs into the system. Nitroglycerin, sublingual, under the tongue, for chest pain. Inhalation, used to concentrate drugs locally in the lower respiratory passages, so bronchodilators, for example. So everything can be taken different ways and have a different reaction. Topical routes, application of medications to the skin, eyes, and ears. So these are your ointments, your creams, your aerosols, anything like that. Drug distribution. Once a drug has been absorbed, it must be transported by the circulatory system to where it needs to do its job and work. Drugs are carried through the fluids into the cells of tissues and organs. If you look on page 238, you'll see there's terms related to drug interaction, so antagonism, synergism, and potentiation. Action of one drug diminishes the effect or shortens the duration of another one. drug enhances intensity or prolongs the action of another drug for synergism, and then the potentiation form of synergism where the effect of one drug enhanced by another drug. So they have two drugs that has two different actions, but one increases the effect of the other. So if you look down on 238, that's why some of the drugs, some will go into effect 30 minutes, some may take an hour. It depends on where they are going, how they are injected. The drug reaction, regardless of the route of administration, they can have one of two actions on the body. Local, which is restricted to one spot or part, or systemic, affecting the whole body as a whole. So most of the drugs are systemic effects. Drugs are believed to combine with body chemicals on the cell surface or within the cell itself. And we have a target cell recipient. This is called a receptor. And the drug that has the affinity for it and produces a functional change in that particular cell is called the agonist. Not all drugs bind to specific cells, so these drugs act as an antagonist to the natural process and work by bonding in a sequence of biochemical events. I'm glad I'm not in pharmacology because I don't think I would ever be able to remember all the medications and how they work. I have an idea with regards to my own medications, but certain anti-infective drugs have a selected toxicity for pathogens or parasites that have already entered your body. Some drugs alter the function of a cell by affecting the physical properties of the cell membrane. A change in the cell membrane alters the permeability of the membrane, which in turn changes the flow of ions in and out of the cell. So again, it's just saying how it can react differently in your body. The drug metabolism. So after your drug's been absorbed and distributed where it needs to go, it's metabolized for excretion. So it's converted into harmless byproducts, which can be easily or more easily eliminated by your kidneys. A lot of drugs are broken down by enzyme activity of the liver. Some of the oral medications that are absorbed into the small intestines begins in the liver. So breaking down the chemical components of a drug can vary among individuals. Some factors that determine the ability include age, what you are taking for other medications, infants, if patients already have liver disease, that can affect the metabolism process. If somebody has chronic liver disease or cirrhosis, they may not be able to metabolize even a small dose of medication. So they can react differently to aspirin, for example. They may not be able to process it. Patients receiving long-term drug therapy can develop overstimulation of the enzyme of the liver, and that makes it have a rapid destruction of the drug. So the patient has to take a larger dose than somebody else because it's eaten up more quickly, so they need more of it. Drug excretion. So now it's been metabolized, it needs to be excreted from your body. So the kidneys are the most important route for elimination of drugs. Chemicals are filtered out of the blood, circulated through the kidney, and excreted in the urine. Drugs are also eliminated through your sweat glands, saliva, and feces. Exhalation, which is another way for getting rid of drugs, serves as the basis for measuring alcohol concentrations in the blood by that lovely breathalyzer test that some people are given. Lactating moms, some medication can be excreted through breast milk, through the milk glands. The combination of metabolism and excretion reduces the amount of drug in the body at any given time. So we have what's called a therapeutic dose of a medication. And this depends on a lot of different factors. The drug's half-life, which is the amount of time it takes for half the dose to be metabolized and secreted from the body. The shorter the half-life, the closer together are the times that it should be administered. So when you hear somebody say they're going to check a therapeutic dose, they're looking for that level of medication in the patient's body. And they can tell how frequently that needs to be taken and if they are taking the correct dosaging. You can see the pharmacokinetic terms that we just talked about, the absorption, the distribution, the metabolism, and the excretion, so the process it goes through in your body. Some factors affecting drug action. So as I said earlier, all people react differently to the same dose of the same medication in different ways. They can have the same reaction as somebody else, or they can have a different reaction. So you can see on page 239, changes with aging. Your stomach takes longer to empty. Your acidity is relaxed. So therefore, it's going to have an effect on the medication. The older you are, your liver functions decline. So the drug doesn't metabolize as quickly. Kidney functions decline. So we have a slower rate of that drug being eliminated through our kidneys. So that can play a factor. Body weight can be a factor. So the same dose has a lesser effect on a patient who weighs more and a greater effect on a patient who weighs less. That's why some medications are based on body weight. Again, we just talked about age, gender. Drugs can affect men and women differently. A pregnant woman can react differently to a medication than somebody else. Women typically have a higher fat body content, less muscle, so less blood vessels. So intramuscular drugs stay in their tissues longer than it does in men. So again, all something for your doctors to keep in mind. The time of day that you take it. Diurnal refers to during the day or time of light. So some medications need to be taken in the morning. Some medications need to be taken at night in order for them to process. Some they can alter depending. Like my medication, it makes me extremely exhausted if I take it first thing in the morning. So they change it and I take it at night so that when I normally would be feeling exhausted, I'm already sleeping. So then I have more of my energy during the day. Some pathological factors. If you have liver or kidney disease, because you're unable to metabolize and excrete those chemicals, that can play a role in getting everybody having different reactions. Patients with liver or kidney disease have increased risk of drug toxicity. So again, more factors. Immune responses. The presence of a drug can stimulate a patient's immune response, causing patients to develop antibodies to a particular chemical. If that drug's administered again, they have an allergic reaction. So here's where your patients can develop their allergies to medications. Some psychological factors. People respond differently because of the way they feel about the medication. So if they think it's going to work, great. If you go into it thinking it's not going to work, that can play a factor. Tolerance. Tolerance is the phenomenon of reduced responsiveness to a drug. Acquired tolerance occurs after a particular drug has been taken for a longer period of time. And then we have physical dependence when occurs for narcotic addictions, and that can accompany your acquired or regular tolerance. Accumulation, when a drug is taken too frequently to allow for proper elimination and accumulates in the tissue. So this can be an overdose or it can have a toxic effect depending on the medication. Idiosyncrasy, This is a response that may manifest in different ways. Hypnotic drug can keep a person awake, acting as a stimulant to that person instead of knocking them out, and it could have the complete opposite effect on somebody else. Drug-to-drug interactions. Again, this is somebody taking more than one medication. Some medications can increase or decrease the effects of other medications. So that's why it's important that your providers know what you are taking for medications, because they are going to be the only ones that know what those interactions are. A big one is antibiotics with birth control pills. Yes, if you've got something that requires an antibiotic, you should obviously take the antibiotic, but that antibiotic can reduce the efficiency of that birth control pill. So while they're on that antibiotic, they will recommend backup methods, for example. Over the next couple of pages, you can see what it does is it lists the drug classification, what the drug is intended to do, the indications for use, and some side effects. So you can see adrenergics is for vasoconstriction. I can't even say that word. Vasodilation reduces blood pressure. Analgesics blocks pain receptors. Anesthetics, insensibility to pain. So you can see they go over all different types of the medication. And then on page 245, 246, 47, and 48, they give you brand names of medication, what the classification is, again, the indication, side effects, and adverse reaction. And this table is your top 50 prescribed medications, and I don't know why it's so old. It's 2014. But you can also Google top 50 prescribed, and you could get you could see if any of those changed. But you can go through and see what those medications are intended to do and what, if any, side effects they have. And that's what we need to be aware of is, again, the side effects. Because if you're looking down through some of these, for instance, there's Cialis, Stelara, Gilenya, all of those, Viagra. One of the common side effects is headache. So for somebody to have a side effect of a headache, it can be the cause from several different medications. So we have to look at those medications and find out which one could be the contributing factor for those. So what we will do there, she's not here yet, is she?
No, she's not.
That's weird. What we'll do, there's not much left for this, but we'll leave off on the herbal and alternative therapies. And what we'll do next week is we'll just finish this, just like 1-2 pages left of that. And then we will start in on the diagnostic coding. And let me see, next week is, just one chapter. So we'll be able to finish this one and then do the diagnostic coding. I am also in the process of double checking, because we are going over kind of like the baseline of coding. If there are exercises on Evolve that require you to look anything up coding wise, what we ask that you do is you can Google CPT, and then you can pull up like CPT code 4, whatever it's asking you to look up, and then you can do your research that way. Right now, they have not required for the billing exam or the MA exam that you need to have the CPT or ICD-10 book for the exam. So we've saved you the expense of those, because they can be quite expensive. Like if you had to purchase, I think I just paid, God awful, almost $700 for the coding books for 2018 for the office. So if you don't need them, we're not going to make you have that expense for them. So what you will need to do with them online, you'll be able to look up online. I know people in the past have said, well, how am I supposed to look up a diagnosis code if I don't have the ICD-10 book? We're just letting you know what ICD-10 is and what the diagnoses are. You're not going to need to look them up for the exam or that type of thing. So, but next week we will start on the diagnosis coding portion. All right, so do you need a quick break in between?
I do. I gotta run to the bathroom.
All right, that's fine, because hopefully we'll give her a few minutes to get here. All right, that's 13. Okay, so that's that. All right, well, we'll go ahead and get started. If not here by yet now. She's probably just going to do it online. But
Right.
so tonight for the insurance should be chapters 9 and 10. Again, we'll see how far we get. Chapter 9 is receiving payments and insurance problem solving. So we'll talk about insurance payment policy guidelines, reimbursement time on claims, components of the explanation of benefits, secondary insurance, 3 health insurance claim management techniques, reason for claim inquiries, problem pertinent claim filing, identify reasons for rebilling a claim, appeals, Medicare's level of appeals, TRICARE's level of appeals, State Insurance Commission, 7 problems to submit to insurance commissioners, and the type of information if we are sending something to the insurance commissioner, what type of information we need. So your claim policy guidelines, unfortunately, they do differ by carrier. So when we get a submitted claim, an insurance company is accepting responsibility to pay the claim, reimburse the medical practice. They can suspend the claim to do investigation to make sure that they should be paying it. They can deny the claim for a variety of reasons. So delay in reimbursements or payments can occur when the health insurance companies state they never received the claim at all. Sometimes the insurance companies reimburse claims lower than expected. What we need to do anytime a claim is not reimbursed at the regular rate is we need to have a way to follow up on that. Because what happens, and it does happen, we've had numerous people speak to us from health insurance companies, and they will say that there has been days that they will come up to the people processing claims and they will tell them, deny those claims today. And that's all they tell them. But they want them to deny them to see if we on the other end are going to take time to follow up and find out why they're being denied. Because if we do, yes, they're slowing down the payment getting to us, but we're following up, we're making sure they should be paying the claim. If we're just taking their word for it that it's not covered, for example, then they're going to continue to do that because to them, they don't have to pay. So we need to have a way to follow up. So to improve cash flow, we need to have a process in place to review and appeal claims if needed. By developing proficient skills and experience for the following up of claims, we can become, again, a valuable asset to the employer and bring revenue that may have been lost because we're not going to take no for an answer. We're going to follow up and find out why they are not paying it. So the insurance company issues a card to the patient as evidence that it takes responsibility to pay the medical practice for services that they receive. So the insurance company dictates the guidelines for claim submission, when services are covered, reimbursement rate, and time limits for submitting claims. So the insured is the patient holding the insurance card. Now the insurance card does not give specific details on benefits or coverage, but it has the patient's ID number, group number, copay information, stuff that is going to start the process for us. It is in our best interest to be aware of the patient's insurance benefit and coverage before we see them. One, so that we know if they have a copay, we collect that up front because we don't have to send a statement. That's already money that we've saved. And 2, if we're scheduling them for surgery or providing a brace or something, if we know what their benefits are, we can have a better idea to know how much they're going to need to pay and if we need to set up payment plans or anything like that. The claimant has an obligation to notify the insurance company within a certain period if it's a result of an accident and or injury and somebody else should be paying the claim. One, if I submit a claim to Medicare, for example, and I've used the code of let's say a wrist fracture, Medicare already, when they see that fracture code, they're already questioning if somebody else should be paying the claim. So they could deny that claim and ask if it's a liability issue. So the members have a responsibility if they are going to be seeking payment through, like, for example, an auto carrier, they should be notifying their health insurance carrier so that they don't pay the claims. Because otherwise, you got to go through that whole refund process. Some policies, the insured can settle a claim. Sometimes it takes up to 3 years from the claim from when the claim is submitted. And provision states that the insured person cannot bring legal action against an insurance company until 60 days after a claim is submitted. Now, with the electronic claim submission, again, this is ease with HIPAA. We submit them electronically, and if the claims are scrubbed and clean and there is no problem, typically you can get your claims paid and back to you within 7 to 10 days. But by also submitting them electronically, we again have the proof that they received those claims. So when they say, nope, we never received it, we have that record that yes, they did receive it, and it's easier for us to appeal that claim and get it paid. We have a fee schedule. So when your physician signs a contract with the insurance company to be an in-network provider, they agree to the fee schedule, and typically it's less than their fee, and that's straight across the board with all insurance companies. They're never going to pay you what you think you deserve for that service. So they will have their own fee schedule. So this is where, if for Anthem, for example, if for that hysterectomy, Anthem's fee schedule says that they pay $2,000, and you've processed claims, and that's what Anthem's been paying, and then all of a sudden you get one claim on Mary Smith, and Anthem only pays you $500 on that hysterectomy. We know that's not normal. That's not according to their fee schedule. So that's one of those that we have to question. Because if we don't question it, they just save $1,500 by not paying us. And then they may try to do it again. The reimbursement time frames, the insurance companies are obligated to reimburse promptly. However, we know that's not always the case. So time limits can vary from one third-party payer to another. Typical 4 to 12 weeks if they are submitted on paper, and as little as 7 days if we are able to submit electronically. If a payment delay occurs and the insurance company is slow or they ignore the time limits to pay the claims, then we can contact the insurance company directly. We can send a letter. We can find out what is going on. If the problem persists, this is when we go to the insurance commissioner. Because if a insurance company is continually not processing claims or paying promptly, if the insurance commissioner knows maybe there's an issue, and they are more apt to be able to get that insurance company to start paying those claims promptly. Because we rely on that payment for our AR, and if you've got 50% of your patient population has Anthem, and you're not getting paid timely from Anthem, that can really put a crimp in that AR. There are timely filing deadlines as well. So with timely filing, you want to make sure that you are aware of those carriers' regulations. Most insurance companies, some have 30 days, some have 90. Medicare, Main Care, they're a little bit more lenient. They have a year. Not that you'd wait a year to submit a claim, but it gives you that availability in those liability cases should they be denied. Managed care claims usually process claims on a daily basis. Some plans only release payments quarterly. Some release once a week. So again, knowing how that works. Explanation of benefits, EOB. Sometimes you will hear it referred to as a remit advice or an RA. So your explanation of benefits is from the insurance company. It tells what you charged, what they allow, what they paid, what the contractual is, meaning what you're going to write off, and then what, if any, patient responsibility there is. Now, your explanation of benefits, should the claim be denied, the reason for the denial will also be on there, so you will have the availability to research it and go from there. The remit advice is the same thing, but Medicare calls theirs a remit advice instead of an explanation of benefits, but you will hear them interchangeably. A suspended claim is one that's processed by a third-party payer, but it's held in an undeterminate or a pending state because of an error or they need more information. So the EOB would tell us that maybe pending medical record receipt, then claim would be processed. The allowed amount is the maximum dollar amount that the insurance company will pay for each service. And that amount would be different depending upon whether your provider is in or out of network with that insurance company. So at the bottom of 297, you will see an explanation of benefits. Every insurance carrier has their own look to their explanation of benefits, but the same information is on it. We have the insurance company's name and address. We have the provider of service, date of service. We have the CPT codes that we billed, the amounts that were billed by the provider, reduction or denial codes or comments. We have a claim number. We have the insured's ID number, the patient's responsibility, any copayment deductible, and then the total amount paid by the carrier. So if you look on 298, you'll see this is pretty straightforward. Right in the middle, it's got the treatment dates, and then it gives the CPT codes, and the 99204, they billed $250 for. You'll see that there's a reason code there, and whether or not we have to look at that later will depend on what they paid or what they didn't pay. You'll see the PPO discount is $136. So of that $250, they allowed $114, and they paid 80% of that, which is $91.20, and then the remaining 20% is the patient responsibility. So that $136, or what's in that PPO discount amount, is what we end up writing off. And you can see it says 48 discount, patient not responsible, because that's above their allowable. So it will, again, reinforce whether or not that is something we can bill to the patient or not. In this case, the only thing we can bill to the patient is their 20%, and this one puts the patient responsibility right up at the top. Some of them put it in a separate column right there with the rest of it. But again, just being able to look at that EOB and see the information that's there. Sometimes it's easy to use a highlighter or a ruler as you're going through and posting. This is really nice because this is just on one patient. But on your Medicare explanation of benefits, it can be 20 pages long, and you could have 20 patients on one page. So as you go down through and post it, it's easier to use a ruler and check off as you're going through and posting, especially if you're not going to be able to post it all at once. Because if you have to go do something else and you come back and you forget who you posted last, that can throw your numbers off. How do we post an explanation of benefits? This is applying the payment to the patient account and writing off any adjustments that we need to. Denials should be presented and reviewed as soon as possible. Many denials or pending claims have a window in which you can appeal them or reconsider them, so to speak. So we don't want to let the denials sit there too long. We want to address them promptly so we don't run into issues. Patients that are billed for the balance or a secondary, or if they have a secondary insurance, then the secondary insurance is billed for that co-insurance, that 20%. So it's during the posting process where we make sure that they're paying promptly. So if I was posting this explanation of benefits and it was for that hysterectomy and they didn't pay the $2,000 that they normally do, then I could either address it right here while I'm working on this, or I can put it in my little tickler file so that I know I need to follow up so that it doesn't get lost in the process. If services are reimbursed but we can't totally understand the EOB, then we need to make a phone call to the payer to make sure that we understand it in case there's any problem that needs to be resolved. A lot of the insurance companies now also have internet access. So with your username and login, you can get right online and you can see the posting, or not posting, but the EOBs and all the explanations on there, and sometimes you may be able to resolve it that way. Claims paid with no errors are designated closed. Again, EOBs can be challenging because they're all different. They have the same information on them, but everybody has them laid out differently. Some EOBs will have one patient, others will have multiple patients. You can create a file cabinet, an e-file cabinet, in your software system so that you always have a link to that explanation of benefits. Our practice management system, it can be scanned right there into that date of service for the patient, or we also keep paper copies by date. So if somebody went and they needed to find an EOB from February 20th, they go into the February folder and it's all chronological by date, and they would also be able to pull it that way. If patients have secondary coverage to cover the co-insurance and or deductible, there are some guidelines for billing secondary insurance. The secondary insurance can't be billed until the primary insurance pays, because they need the explanation of benefits knowing how much that secondary insurance is responsible for. And on your claim form, it will end up having information about the primary insurance that says what they paid on the claim, so that the secondary knows, again, with that EOB, what they're responsible for. Block 30 of the HCFA form will have the balance, so again, what they're liable for. Depending on the state contractor, with Medicare, Medicare is the only one that will automatically cross over to some secondary payers. So, for example, Anthem Blue Cross and Blue Shield, if the patient has secondary coverage and Anthem has that in, and Medicare has that in their system, they will cross that claim to Anthem for you, so you don't have to. Main Care through the state, Medicare automatically crosses over to Main Care, so you don't need to resubmit to Main Care. But you're going to have some instances for those Aetnas and those Cignas where you're going to have to resubmit them. Medicare's EOB, right underneath the patient information, it will tell you if they submitted to the secondary insurance for you. It will say claim forwarded to Anthem, claim forwarded to Main Care. If you don't see that and you have your patient as having secondary insurance, then you know you need to send that, because they did not. They didn't have that information. And again, they need that explanation of benefits. Paid claims that have an outstanding balance needs to be kept aside to monitor to make sure your secondary insurances pay. And again, we mainly do that by your accounts receivable reports that you can run. But again, you will see with Main Care, if they are the secondary insurance, this is the last paragraph on 299, if Main Care or Medicaid is assigned as a secondary insurance, Secondary insurances may claim that the amount paid by the primary insurances exceed their allowable. If that is the case, then guess what? Main Care is not paying anything. Patient can't be billed. You need to eat it. A good example of this is somebody having Cigna, and you have a $40 copay with Cigna. Okay, but the patient also qualifies for Main Care. So you bill Cigna, Cigna says patient owes you, or Cigna says there's $40 due. You bill that to Main Care. Main Care is going to come back and tell you that Cigna already paid you more than Main Care would have for that visit. So that $40, you can't even bill your patient even though it's their copay. You have to write it off. So one bad thing about Main Care secondary to regular insurances. EOB management after you post payments and adjustments. Again, paper EOB filed in the designated area so that you have access to that. And again, filing limits, typically 7 to 10 years for anything related to patient accounts as well. Claim management techniques. Since most claims are submitted electronically, there are batch claim reports and scrubber reports that you can get from your clearinghouse that will tell you how many claims were submitted, how many claims were accepted, how many were denied and sent back or unprocessable, so that you can fix them and send them back through. That way we have a way to ensure that every claim is processed so we do not have delinquent claims or claims that are waiting longer than 30 days to get paid. When the claims are paid off and they have a zero balance, they're considered purged. So what happens in your medical software package is if they're paid off and it's a zero balance, they're not going to show up on any of your outstanding reports. You can still go into the patient account and see that they've paid it, but it's not going to show up in your AR as being outstanding. Once they come back and they regenerate charges, that will repopulate at that point. And you can run an aging report and remove all accounts that have a zero balance if your practice management system does not close that out automatically. And aging reports should be run on a monthly basis. Most of your practice management systems can run them by 30, 60, 90, and 120 days, and then you can do appropriate follow-up. So our system runs it, and I get those 4 columns. So I know what's 30 days, I know what's 60, what's 90, and what's 120, so that I can start, typically I start with the 120, and if there's anything in that block, then those are the claims that I will address first. I'll go in the system, see if they've been resubmitted, see if there's a note that says why they're delayed. If I need to make a phone call, then I'll call and address it. If I just need to resubmit the claim, I'll resubmit the claim. But by doing that, you're always making sure that you're not letting your claims go too long, that you're going to run into issues. You can write notes on your aging report. Again, phone calls to the payer, what needs to be corrected, rebill, anything like that. Because time is of the essence, again, be aggressive on claims outstanding for more than 60 days. And again, using your practice management software's monthly reporting, that can track the payment history of the insurance companies. So if we were also looking to see if that insurance company is paying within 30 to 60 days, we would be able to do that. Or if this particular claim is over 120 days old because we're having issues with that carrier paying claims, and maybe that's one we need to go to the insurance commissioner on. Unpaid claims more than 30 days old should require an inquiry on the claim, meaning we contact the health insurance and find out why it's being delayed. Sometimes it can just be a quick issue, and other times it may be something that we really need to address. To reduce the number of phone calls to the insurance company, again, we have online physician portals, so we can log on and find out what's going on. Plus, we can actively carry on a conversation via typing while we're looking at that claim situation right online, instead of being on the phone. The reason we would make an inquiry if they do not respond to a claim within 30 to 45 days. If we do not get payment within a certain time frame, payment is received but amount is incorrect, payment received but the amount allowed and the patient responsibility is not defined, duplicate payment or overpayment, payment received was for a patient not seen by that provider, the check was made out to somebody different than your office practice, anything like that. In addition to non-payment or reduced payment, some other reasons for inquiry is that the EOB shows a CPT code that is different than what we actually submitted, which I have happened sometimes that I will submit a claim for our assistant surgeon. She's a nurse practitioner. So when she's in surgery, she uses the modifier AS. I'll get an EOB and they've changed the modifier to 80. So I have to call them and say, no, 80 applies to an MD. She is a nurse practitioner. The modifier AS needs to stand. And they will have to reprocess that claim because they took it amongst themselves to change the modifier and assume that she was a doctor. The service was disallowed when indeed it was covered. Additional information was needed and received, but they still haven't paid. The claim needs to be revised or resubmitted. So again, just anything that they're questioning, we need to question why they're doing it. You can see on 302, this particular office has a letter that they send in. This is saying that they're requesting a review because the skin graft was included in the lateral third of the eyebrow. It was full thickness. So in other words, the doctor, when they got the reimbursement, they felt the reimbursement was too low. They didn't include what the physician felt he should have gotten paid. So they submitted this with the operative note in hopes that they would review that and possibly pay the provider a little bit more. You can also do a inquiry or tracer on government health plans. They have forms available online that you can submit. So some of them will not even take a phone call from you. They will say any inquiries about claims need to be done online. Problem claims. Problems in claims filing will result in late reimbursement. So again, we want to receive payments timely, so we need to submit them timely. It's not efficient for the medical office to follow up on a claim less than 60 days after the date of service. If there's a problem with the claim, you'll know about it before that. But typically, because it can take 4 to 8 weeks for claims to be processed, give them the 60 days. Don't follow up on it sooner. It's not going to make them pay it any quicker. Many types of problem claims can be delinquent, suspense, lost, rejected, denied, only give you partial payment, they paid to the patient, or they overpaid. So these can be problem claims. And again, they need follow-up action. So if you look on page 303, here are some, again, processing issues. So for denied claims, payment overdue from the non-payer, meaning they haven't paid their policy. Lack of insurance coverage, they're not covered. Maybe they have a different insurance company. And you can see some different reasons. To prevent repeated claims errors, if the office manager understands a reason for the issue, then they can typically fix them. Meaning, if it's starting with the front desk, for example, if the names are not being put in properly, or if the dates of birth are incorrect, or if the insurances are being sent to the wrong address. That's a big one, because on every insurance card on the back it says send claims to, and it will have an address. When you search in our system, if you search for Anthem, it will bring up numerous anthems, but you don't just select the top one because it's the first one that pops up. You've got to make sure that your claims are being sent to the correct address, because that will cause a denial or a delay if it doesn't show up at the right place. So the individual working at the front desk needs to collect the correct insurance information, update demographic information, copies of insurance cards. They should be verified at every visit. The person posting to accounts must be certain to post to the correct patient account. Ensure that secondary insurances are billed after the primary, or if there is no secondary insurance, that the patient is going to get their statement for their responsibility. There is a significant difference in the way problem claims are handled when filed by paper or electronically. If you look on 304, it goes over, here are some types of problems. So we have a delinquent, pending, or suspense claim. So they're beyond 60 days. The non-payer can be an insurance company, TRICARE, Medicare, whatever. The carrier may be investigating a claim because of pre-existing conditions, non-covered. Sometimes there's no response. However, we need to do a follow-up. So what do? If it shows up on our report, it tells us work on one group each week. So the work spread out over 4 weeks. Visit the online provider web portals to check claim status. Look for evidence of the claim being submitted with your clearinghouse. If the information is correct, dates on the claim correct, contact the payer to find out what's holding up the claim if you can't see a valid reason for that. If the claim never was received by the clearinghouse, then we all obviously need to get that claim resubmitted to them. So we can contact the clearinghouse. Why was that claim rejected? Why did they not receive it? And then we can contact the payer immediately or directly after finding out what's going on to see what we need to do. If the claim is lost, how do we handle that? So we need to contact them. Again, if it's over 60 days old, all lost claims should be resubmitted. Typically, when you do that, if it's a lost claim, you submit a copy of the original claim, and we tell them this is a copy of the original claim so that they can see it was previously submitted. Lost claims are crucial to manage care. Many have deadlines for filing. So again, we need to make sure we have that original claim so we can prove we sent it. Rejected claim, a claim that doesn't follow third-party payer instructions or has a technical error. So it can be an incorrect date of service, incorrect year of service, missing ID number. What do we need to do? Numbers were transposed. You build an office visit code with a place of service in the emergency room. Those do not match, so that would be a rejected claim. So we need to look at it, find out what that rejection was, and then submit a corrected claim. And there's a couple of different ones there for the resolution for rejected claims. Also, for paper claim solution, review the EOB for the denial code. So if we get that paper EOB and it has like that number 48 and it said rejected for medical records, we would know that that's why that claim was denied, and we can send those medical records. One of the most common denials is medical necessity, which means the insurance company is denying that the patient needed the medical service. A lot of times this is just because the diagnosis code doesn't support the CPT code. So for example, for an injection of a trigger finger, they will only cover trigger finger for a trigger finger diagnosis. So if you put pain in finger and you're using a trigger finger injection code, that's not going to be covered. So sometimes that's all it is with medical necessity, is that your diagnosis code does not support your CPT code. So the same thing with hammer toe surgery, but you use a diagnosis for a broken wrist. Obviously, that's not right. 306, a denied claim occurs due to denial of health insurance benefit coverage policy. So when a claim is denied and the responsible party is found to be the patient, you transfer the entire the entire balance to the patient's account. However, the exception is with Medicare. With Medicare, the only way we can transfer a denied balance to the patient is if we have the patient sign an advance beneficiary notice stating that this is a service that Medicare will not cover, and if they do not cover it, the Medicare patient agrees to pay for it. If you don't get that ABN signed, you will eat the cost of that visit. The appeal process varies among third-party payers. Medicare claim needs to be redetermined by requesting a review in writing. Some reasons why insurance claims are not paid: because of denial, diagnosis code's not covered, frequency limitations per benefit period. So, for example, some people having physical therapy, their insurance companies may only cover, let's say, 24 visits a year. If they've exceeded those number of visits, that's a good reason why it's going to be denied, and the office would have to appeal that, but we would have to appeal it with the therapist's documentation of why that patient needs more than those 20 visits. Prior approval needed was not obtained. Again, the diagnosis not supported by the service, missing or incorrect place of service. So again, a lot of different reasons why we may need to appeal claims. So you can again see some problems and solutions. Medical service provider was not covered for the patient because it was routine. Send the patient a statement with the notation from the insurance company. And always verify coverage before you do anything. Insurance coverage canceled or lapsed prior to date of service. So again, verify their insurance. Make sure they're eligible at the time of service. And again, a lot of different services not pre-authorized for a surgery. So have a policy in place where anybody you schedule for surgery, you call the insurance to see whether or not it needs an authorization. That way you're doing it straight across the board for everybody. You're not doing it just for certain carriers. On 307, prevention measures to avoid denied claims. So again, be proactive. Verify that insurance coverage. Our system does it electronically. When the patients check in, we can check verify eligibility once we have their insurance in the system. And most of the insurances will verify electronically and tell us whether or not they're covered. Include progress notes and orders for test extended hospital services. That way you're not waiting for them to request the information. You've already sent it, and they'll process the claim that much quicker. Submit a letter from the prescribing physician documenting necessity. This would be in the case of ambulance transportation, because that's a common one that's denied. Clarify type of service. Use modifiers to identify exact service rendered. Keep abreast of the latest policies for your payers. That includes Medicare with their local coverage determinations or their national coverage determinations, meaning that there are codes out there that Medicare will only pay for if you use certain diagnosis codes. So if those are going to be common procedures that you do, you want to make sure you keep those local coverage determinations handy. Obtain current provider manuals for the insurance carriers. Become familiar with the modifiers. On page 308, downcoding. Reduced reimbursement is the result of downcoding. So your procedure or diagnosis code is general or unspecified. So we would need to review the procedure notes and the orders to see if we could use something more specific. If we are able to use something more specific, then it's possible that they may have paid us the full amount on that hysterectomy claim instead of the only $500 that they gave us. Payment made to a patient. This really irks me, but if your provider does not participate or is out of network, it is possible that they will send the checks to the patient and you don't know that they've gone to the patient until it's over 60 days old and you're calling to find out what happened with that claim. You have to, once you do that, you call the patient, explain that the insurance company sent them the check, provide them as much information as you can. Typically, the insurance company will give you the check number and the date and the amount, and then ask them when we can expect to get that payment. A lot of times when they get a check from an insurance company, they think it's because they overpaid their premium, and they don't realize it should be going to a provider. So the quicker you can follow up on that, the more apt you are to receive your payment. If you receive a two-party check made out to both the physician and the hospital, and the only part of the sum is the physician's payment, and you don't get an EOB for the breakdown, then you need to call them, let them know. Sometimes this is going to require that you turn in a W-9 or a 1099 to the IRS. They are paying under the hospital's tax ID number but have your provider's name on it, and that's not going to work out for tax time when you're not going to be able to, one, cash that check and post it to your provider for his portion without an EOB, and then turn around and pay the hospital if you're a separate entity. Under payment, here we want to make sure when you first sign up with a insurance company that you monitor and make sure they're paying you according to their fee schedule, especially within the first 3 months, because sometimes they can underpay you, and again, we want to make sure that that does not happen and we follow up on them. If they pay incorrectly, we can send them a copy of the contract so that they know how much they were supposed to be paying and ask for that to be redone. With an overpayment, it does happen where they pay twice for the same date of service. I don't know how it happens, but sometimes if the system submits the claim twice, it can be done that way. If the claim is rebilled, anything like that. An overpayment is a sum of money paid by the insurance company to the provider for a service that is more than the account balance or the allowed amount. Some states have laws or court decisions restricting managed care plans and other insurers from recovering payments made in error from providers. Other states will not allow insurers to recover if the provider changed its position, but they're relying that the provider will refund the money. We want to have a overpayment policy in place because, especially with the federal government, supposedly you only have so many days if they overpay you to refund that money. If you do not, and it is found that you've held on to that money, you can get fined and penalized. So have a payment and policy in place for those overpayments. And again, some scenarios with the receiving payments and what to do. Refund checks should be given top priority, written as soon as reasonably possible. If it's a patient and they've overpaid, either call the patient and let them know why they're going to be getting a refund check, or when that check is issued to them, enclose a note as to why they're going to be getting a refund check. If they pay by credit card, we want to make sure that the charges have cleared, and then we can refund that credit card if that is the case. If the patient can't be located to return the money, send a check by registered mail to the last known address, and when it comes back undeliverable, that is your legal proof that you attempted to return that refund. So you want to make sure that that is another case of when you are using registered mail return receipt requested. If you look on 310, there's a couple of different overpayments from, for example, Medicare or a managed care plan. Some of the carriers will realize that they've done it, and they will automatically take it off another explanation of benefits that they are paying you for somebody else. And that's clearly marked on there. Others will send you a letter saying, we've overpaid, please process a refund. Rebilling. If a claim has not been paid within a reasonable amount, do not automatically resubmit or rebill the payer without researching the claim. If we automatically rebill a claim after 60 days because we haven't heard anything, one, we may be wasting money if we're getting billed to if we're getting charged to resubmit that claim. But two, if we are resubmitting without doing research, the insurance company could take that as a duplicate claim, and we could end up with a duplicate payment. So we need to find out why before we resubmit. Our practice management system, we get charged X amount every time we submit a claim. So I'm not going to automatically resubmit because I know we're losing money on it. So I make the effort. Patient accounts that have a balance should be billed on a monthly basis. Obviously, your patient accounts typically go on a 30-day cycle. Depending how you want to do that, some offices will do it by alphabetizing it. So the first of the month, A through L, patient statements are generated. The 15th of the month, M through Z. That way, you have a way of telling your patients when they should expect their patient statements. Ours goes by when we receive the payment from the insurance company. So if we receive the payment today, tomorrow that statement will drop to the patient. And then they'll have 30 days before they get the next one. Review and appeal process. So an appeal is a request for payment by asking for the review of claim. The review of claim can be one that's underpaid, incorrectly paid, or completely denied. In Medicare's world, they call the first level a redetermination, but there is a time limit for appealing the claim. So before you start that appeal process, check with that payer to find out how their process works. Most of the appeal processes or reconsideration processes are right online, so you can clearly see what that time frame is and what you need to do to get that in. Appeals can be time consuming and costly, so one, you want to make sure if you're going to take it to court level that that balance is large enough that it's worth going to court for. You want to make sure if you are appealing it, you have all your documents that you need, remain courteous, obtain name, extension of the person or the adjuster that you're talking to so that you have all that information. Jot down date, time, take notes. An appeal can be filed if payment is denied and no denial reason known. Payment is received but amount is incorrect. Physician disagrees with the payment. Unusual circumstances warranted medical treatments not reflected in the payment. Pre-certification was obtained, but the claim was denied. inadequate payment for a complicated procedure and not medically necessary as the denial reason. So again, how do you appeal a claim? If the appeal is won, but copies of the same documents must be submitted each time the same issue arises, ask the third-party payer how future claims with the same issue can be handled. Maybe there's something that can avoid having to go through this appeal process for that same reason every time. Appeals need to be in writing, most of the time on their insurance company special forms. Keep track of the status, so in other words, have a tickler folder for the appeals to make sure that they're being followed up on. If an appeal is then denied, your physician can require a peer review, meaning that they will have a medical staff person call your provider and they can talk about the medical issues as to why. We had, for example, a person who had an MRI. The MRI clearly showed that the patient had a rotator cuff tear. So our doctor went in, repaired the rotator cuff, and we called the insurance company. We got it approved. The MRI was done. They still denied the claim. So we did the appeal. They still denied the claim. So we asked for a peer-to-peer. So our doctor talked to one of their doctors and said, how can you deny that? The patient had an MRI with a tear. What ended up happening is when we submitted the documentation, they separated the MRI and they didn't have it with their documentation. So to them it looked like the patient never had one. So once the doctor actually could see the MRI, because we electronically emailed it to him, he was like, oh, that's clearly a tear. We'll send that for reprocessing. But it took a denial and then it took an appeal. But that's why we never take no for an answer, because that was, $3,000 we would have been denied had we have not gone further with it. Additional information on tracing delinquent claims. So again, have a way for following up on those claims. For Medicare, again, they have their process. So level 1 process is what they call a redetermination. It's on their form or by telephone, and they give you the number of the form. If that's denied, we then go to level 2, which is a hearing. Then we go to level 3, administrative law judge. Level 4, the appeals council. And level 5 is district court. So the redetermination is level 1. And if you look on 312, again, it's a form on page 113. This is the first level of appeal. So we have to put the date the initial determination was made, why we do not agree with it, what additional information they need to look at, and then we date and sign it and send it in with that additional information. If the claim was denied because of a simple error made by the insurance billing specialist, then like the NPI number, for example, we can complete that form saying we made an error, we left off the NPI, and send it in with a new claim for it to be processed. The level 2, and if you look up at the table at the top of 312, for that redetermination, we have to do it 120 days from the initial denial. Then the second one is 128 days from the receipt of the MRN, or 60 days, and then the AIJ, 60 days from the hearing determination. So if we're not staying within those timely limits, they're not even gonna look at it. They will just say, sorry, you didn't follow our protocol. So again, I take the 5 levels for Medicare, and I have them in a Medicare folder, and I'll put level 1, and I write right on it, 120 days from denial. So that way, that is a clue to me that I can put it in a tickler file within that 120 days and make sure that I'm still getting it in promptly. So the level 2 would be within 6 months from the date of the original determination on the RA. And with this request, we attach the original insurance claim, the copy of the remit showing the denial, photocopy other documents, op notes, anything we need to help the reviewer look at, and the reconsideration form with the justification of why we want it sent. Now the level 2, they have to be mailed certified mail with return receipt requested. If they're not sent certified mail, they won't even look at it. They'll send it back to you. If you look on page 114, there's the form for the second level appeal. Not really much different than the first level appeal, other than it says second level appeal. It still gives you, and it asks for the date of the redetermination. But it tells you to send all requests to the review department. Third-party payers usually complete a review within 30 to 45 days, so then you can make an inquiry after that. If certain procedures are constantly denied, ask the carrier what information they need in order to get it processed. If it's the same information every time for that particular procedure, then we know every time we need to do that procedure in order to avoid this process, we've got to include the op note, for example. On 315, this is the appointment of representative. So this is the next level, the law judge, and the amount has to be $150 or more. Again, 60 days of receiving the reconsideration officer's decision. This one may take 18 months to get an assignment for an administrative law judge. So for me, if I'm going to wait 18 months for $150, it may not be worth it to keep it open on your books that long. Level 4 is the appeals council. So again, 60 days of the administrative law judge decision. Day 2 of the administrative law judge form is on 316. And then you have the district court, which has to be over $1,400. You have to hire an attorney. The case can be filed where the physician's business is located. But again, to get it up to a level 5, you better make sure that everything is documented properly and it's worth the expense, because if you're taking it to court, your provider's going to have fees with attorneys and stuff like that. So, Centers for Medicare and Medicaid regional offices. You can write or telephone the medical director at one of the regional offices if you are having issues with Medicare and or Maine Care. They do have local representatives. I believe the regional office for us is located in Boston, but they do respond really quick to emails, which is nice. You can, they do want to help you. But I think they're over inundated with a lot of stuff, so they do get back to you, but you can use them as another resource. Medigap, insurance companies that sell Medigap policies need to be certified, and that certification can be lifted if they do not honor their contracts. When the Medigap insurance is Maine Care, in most cases, here again, your secondary payment would be written off. Because if what the primary pays is more than what Maine Care allows, they're not going to pay anymore. TRICARE, again, they have a different review and appeal process. A provider who treats a TRICARE patient but is out of network is not able to obtain information from TRICARE. You have to contact the patient, and the patient can get that information. But all TRICARE inquiries are done through the online provider portal or the automated phone systems. 2 types of TRICARE appeals, expedited and non-expedited. Expedited needs to be within 3 days of the receipt of the initial denial. They should include an expedited review of, this one's typically done for a prior authorization. Non-expedited appeals no more than 90 days after, and this you send a letter to the appeal department stating what's going on. You attach the claim form, medical documentation. The TRICARE contractor reviews the case and makes a decision. If it's non-favorable, the next level of appeal is TRICARE quality monitoring contractor, in which, again, you send a letter, all the documentation. This one also is 90 days after the date of appeal. And then if that's still denied, you can issue a second reconsideration. But if it's less than $300, then they say don't bother, their denial decision is final. If it's more than that, then you could still dispute it beyond that amount. But knowing what insurance carriers, what their process is for the appeals. Reconsideration, sometimes you can request just a reconsideration instead of an appeal. So for a TRICARE, that can be non-participating providers, medical necessity, hospice care, denials or partial denials for pre-authorization, coverage issues. TRICARE will not pay for services before or after a certain date. Matters on 318 with TRICARE that you cannot appeal. You can't appeal a denial from a provider or not authorized to provide care under TRICARE. You can't do an appeal for a eligibility denial from TRICARE. So knowing what you can, or when you can and when you cannot appeal as well. Again, for here, the redeterminations or reconsiderations, they need to be sent in the state of which services were provided and postmarked within 90 days that you receive that summary. So again, times. Our state insurance commissioner, what is their objective? The insurance industry is protected by the Federal Trade Commission, and the state insurance departments want to make certain that the financial strength of the insurance companies are there. They monitor the insurance companies and make sure that they're processing claims timely, that they're paying you properly. Verify all contracts are carried out. All organizations are authorized to transact with that insurance company or broker. Release information, or if you're requesting information from the insurance carrier and they're not giving that information back to you, such as reasons claims are denied. To assist if a company funds its own insurance plan, and to help resolve insurance conflicts. So the commissioner can hold a hearing to determine whether these insurance carriers or agents are acting properly. They review the policy to determine whether the denial of a claim was based on legal provisions of their contract. Problems that need to go to the commissioner would be an improper denial of a claim or settlement for an amount less than what they said they were going to. Delay in settlement of that claim, illegal cancellation of the insurance policy, misrepresentation by an insurance agent or broker, misappropriation of premium payments, problems about premium rates, and two companies that cannot determine which is primary. Believe it or not, we have this happen all the time, and there's supposed to be something called, well, there's a couple of different things, but if I'm working and I take my company's insurance, but I'm also covered under my husband's, my policy at work would be primary, and my husband's policy for me would be secondary. In some states, that's not how they do that. In some states, they follow the birthday rule, which means whoever's birthday is first month and day-wise would be primary, which in this case would still be me because I'm April and he's September. But we have had the instances where Medicare will pay adamant that they're primary. And then we get an explanation of benefits from the secondary insurance, and they're paying as if they're primary. So we call Medicare, verify. They said, nope, we're primary, secondary's Aetna. We call Aetna. Aetna says, nope, we're primary. If they can't decide which one of them's primary, somebody's overpaid. So who do we refund? They're both saying, no, we paid correctly. So this is when we have to send to the insurance commissioner and say they're both paying as primary. We have money to send back. Somebody's got to get their act straight. And they'll determine which should be, or not determine, but they'll call them, figure out, and then whichever one is not, then we can refund the money rather than holding on to money that does not belong to us. But sometimes that's a big issue. The insurance companies, they're both adamant that they should be paying as if they're primary. So an insurance billing specialist may not be in a position to know the particulars about the case, but we can send requests to the insurance commissioner. We can submit them online. And when we do that, again, there's a couple of things that need to have in the information. The inquiring person or patient, policy holder, name, number, policy holder's address, telephone number, insured name, address, and title of the insurance agent or company, a statement of the complaint. So if we have a copy of their policy or their medical bills or canceled checks, which probably is more the patient than us, patient signature giving us the okay to submit this, and name and address of the insurance carrier, agent, broker of the finance company if a premium was financed, policy number, date of loss, and the date the patient filed the complaint. So again, we can have numerous things on this. If the insurance company is continually a slow payer, we can submit that to the insurance commissioner. That is something that they can research. We can file a complaint against that carrier for slowly processing claims. Again, you can also send a letter with certain information. The attached claim has been submitted to XYZ. It has not been paid or denied. Please accept this letter as a written complaint. Insurance companies are rated according to the number of complaints they receive about them. So they don't want people to contact the insurance commissioner. So they should be processing their claims promptly. But if they do not, we need to provide that information. So if you look on page 320, this is an example of a letter being appealed by a physician. Now again, I talked about most insurance companies, particularly Medicare, you saw, has their appeal forms. If an insurance company does not have an appeal form that needs to be filled out, then you could use a letter such as this, documented by the physician, and what the information is. So here, what his fees were. They're saying, here's the photocopies of the report, path report. He considers this, the allowance paid, very low, considering the patient's condition prior to surgery, and he hopes they will authorize additional payment. So if there's not a form for that insurance company, then you can go ahead and do a letter. Obviously, keep a copy of the letter because that's your only proof that you've appealed it. And if you do a form, you also want to do the form as well. Any questions on the claims process or receiving payments, problem solving?
No?
No. Pretty straightforward.
Yeah.
All right, now we were supposed to start chapter 10 you can see chapter 10 is a fairly long chapter. Next week we are supposed to do chapter 11, which is just Anthem, which is a shorter chapter. Looks like we've got about 10 minutes. I can either start chapter 10 or we can wait and just start it next week so we're not just a couple of pages in. What do you think?
I think it'd be better to start it next week.
Start it next week?
The new chapter.
Okay.
Get through the whole thing.
Yeah, and that way you don't have to worry about anything you have to do online either, because you're going to have to wait till you finish it anyways.
Right.
Okay, so we will do that then. Next week we will do office and insurance collection strategies. So we'll be talking more about the AR and the money flow and types of ways that we can collect balances. And then you'll see the next few chapters after that, we're going to talk about the individual insurance companies. So we'll talk about Anthem, Medicare, TRICARE, workers' comp, and then we go into disability, hospital billing, and then you're done. So we're getting there.